My name is Benjamin Domb. This is a presentation on dysplasia and its arthroscopic indications. We'll go through the diagnosis of dysplasia, the importance of per-acetabular osteotomy, or PAO, the indications for arthroscopy, a case, and some outcomes. In terms of the diagnosis, amongst the major causes of osteoarthritis in young adults are acetabular dysplasia and femoroacetabular impingement. Dysplasia is essentially a shallow socket, or shallow acetabulum as we use it most commonly, which may cause a labral tear, may cause acetabular rim overload, and ultimately cause arthritis. Weiberg described the lateral center edge angle and defined the threshold of 25 degrees or more as normal, 20 to 25 as borderline normal, and less than 20 as dysplastic and pathologic. In terms of the natural history, the lack of bony support causes increased load on a hypertrophic labrum, which causes labral tearing, anterior-superior migration or subluxation, and eccentric loading of the acetabular cartilage, which ultimately results in arthritis. The PAO is critical in the treatment armamentarium for dysplasia. It is the first line of treatment. It is the only surgical solution which actually corrects the deformity, and arthroscopy should be considered only if PAO is not an option. PAO involves a per-acetabular osteotomy where the acetabular fragment is rotated in order to increase the coverage of the femoral head. On the left, you see a preoperative x-ray showing a severely dysplastic hip with a center edge angle of approximately 0 degrees. And on the right, you see an x-ray after per-acetabular osteotomy showing correction of that deformity. So, who is not a good candidate for a PAO? A high-level competitive athlete, those with mild dysplasia in the range of 20 to 25 center edge angle. Those who are greater than 50 years old probably are not good candidates, and those who have pre-radiographic osteoarthritis that may show up on MRI or advanced studies such as a degeneric MRI. X-ray changes of degeneration such as joint space narrowing or subluxation of the femoral head are also contraindications to PAO. So when is arthroscopy indicated? The indications start with those who are not a candidate for a PAO. Patients who do not have joint space narrowing, no lateral migration of the femoral head, and those less than 55 years old, because the older dysplastic patient may be better served with a total hip replacement. One of the major indications for arthroscopy in our dysplastic population is as complementary to a PAO. Now, most commonly, this is done in our practice concurrently with osteotomy. So we'll first perform an arthroscopy, address any intra-articular pathology, and then perform a per-acetabular osteotomy. Pre-osteotomy, it may be used as a staged procedure in the in-season athlete to provide temporary relief of pain until a planned PAO. And post-osteotomy, if there is persistent pain due to a labral tear or cartilage flap, those intra-articular pathologies may be addressed arthroscopically at a later time. Here's a case of arthroscopy in dysplasia. This was a 22-year-old female with 2 years of right hip pain. The degeneric MRI showed an anterior superior labral tear and a borderline degeneric index of 370. We found a very large labral tear arthroscopically. You see this is a hyperplastic labrum on the left, about 10 millimeters in thickness, completely disrupted from its attachment to the acetabular rim. So this cannot be treated with arthroscopy alone because it will fail. A labral repair in this setting will fail due to edge overload. So we treat this with concomitant arthroscopy and per-acetabular osteotomy. In addressing labral tears in dysplasia, do not resect the labrum unless planning a labral reconstruction because of its importance in joint stability and absorbing load. If we resect any part of the labrum, we risk increasing instability and risk subluxation after the labral debridement or resection. We've published the technique for labral base repair or labral base refixation in the hip in the journal Arthroscopy, and this may be done with various suture configurations as seen in the right. The goal of all repair techniques is to restore the contact between the labrum and the femoral head so that we restore its suction seal and restore normal mechanics and stability of the hip joint. We also augment the procedure with a capsular plication in all cases of dysplastic hips. So in dysplasia, instability is the problem, and therefore we want to preserve and usually plicate the capsule, so tighten the capsule. A concomitant PAO treats the underlying problem, and that's what we performed in this example of the 22-year-old patient. So we repair the labrum arthroscopically, we tighten the capsule to treat the ligamentous laxity, but we also must correct the underlying bony deformity in this type of case. In terms of outcomes in dysplasia, there have been some good results published in the past. This was an early series from 2003 by Thomas Bird showing better results in younger patients and those with acute onset of symptoms. There have also been disastrous outcomes that have been published. This was a series published in 2009 of 34 arthroscopic labral debridements with a very high failure rate. 24 patients failed to relieve pain, and there was acceleration of arthritis in 14 patients. 13 patients had migration of the femoral head, and 16 underwent further surgery. So disastrous results here. So our study, which was a multi-center study, found 14 labral tears in 17 hips, 16 examples of chondral injury, and 10 CAM lesions. So a very high incidence of intra-articular pathology. And for that reason, the approach at our institution is to treat patients with dysplasia with a concomitant arthroscopy and per-acetabular osteotomy so that we can address the intra-articular pathology such as labral tear and also address the underlying dysplastic deformity with the osteotomy. In summary, PAO is the first line of treatment in treating the dysplastic hip. Concomitant arthroscopy and PAO is our method of choice because we've found that 100% of patients undergoing a PAO have intra-articular pathology. For those with a lateral center edge angle greater than 18 in the borderline dysplastic category, arthroscopy alone may be successful if the labrum is repaired or reconstructed and the capsule is plicated. Thank you, and my name is Benjamin Domb.